can go back to here. We can move back
push
to
the
the
table back.
Yeah. Careful, watch it. Yeah.
Trying to push this thing back so I can have a little bit more angle here. All right, now.
Better.
Let's go up a little bit more. Up a little bit more. Okay.
Is it? It looks funny.
Slanted.
Window. Okay. Turn it. Gotcha. Like
Yeah.
this. That's better.
And then
More this way.
Which one?
Going towards her. Because
yeah. Okay.
And then up a little bit.
Okay.
How does it look?
Just a little bit of
The crookedness?
Yeah.
Yeah, it's bothering me too.
put this under it if you want. You want to pick it up a little bit?
I think we're good now. Check it out. Yeah. Better? What do you think, Doc?
We are live.
We're live.
Are we
Yes.
live?
Yes, we are.
Yay, we're
Yeah.
connected. Finally. It has taken an
Yeah.
act of God. We had to move locations, come
Yes.
to our area
Our
where,
provider room.
yeah,
and
where we would do all our
leave our
work.
conference room. So
Yeah, I think the
sorry
internet
about that.
connection wasn't working in the conference room, so we're so sorry, guys.
Yeah.
But that's okay because we're still gonna give you all the good stuff,
good
right?
data.
About geriatric,
Geriatric
depression.
Yes.
So, what is depression? Let's refresh our audience on what depression is, Dr. Bharti.
So first thing, thank you for having me here. I'm, as usual, thrilled, excited to be here. We're talking today about geriatric depression. And last time we did a part 1 of geriatric
Part
depression
one.
where we talked, I'll give you a little bit of brief introduction to geriatric depression. So quickly, depression, I want to say in geriatrics is not a normal part of growing older. Please do
Yes.
not consider depression as normal aging. And the way to define depression, I would say, is due to physical, emotional dysfunctionality. Patients are unable to achieve their activities of daily living and unable to be in a better emotional capability to conduct their day-to-day living. A lot of things that we see in geriatric depression is very classic and typical and not the same picture as we see in our younger population. Not everybody will be coming to you and saying, I'm sad all the time, or they're crying all the time. The very common symptom of depression in geriatrics I have seen is feeling excessively tired, excessively sleeping, and not wanting to do any activities
Anything.
that give them pleasure. One of the things, if they were socializing before with their friends and used to play bingo, well, they have stopped doing that and they're not taking pleasure in their usual activities. And then the depression becomes very clinical, where patient is unable to eat, sleep, carry out their errands, carry out their daily activities, carry out simple things of
simple like
simple
ADLs, their
yeah.
activities of daily living.
bathing, grooming,
Yes.
or IADLs where they can't balance their checkbooks, cannot make critical thinking. So when you have your loved one suffering from somewhat of what you think could be a depression, please come to your primary care and get it checked out, because I will repeat it again, depression in geriatrics is not a normal part of aging.
It is not. And, you know, like we were talking about earlier, while the thing was disconnecting, we were having an entire...
Yeah, you were telling me about
we're
your
having our
patient.
entire conversation, and we brought up the issue of dysthymia. And dysthymia, this, you know, now in the DSM-5 criteria, they call it like a chronic depressed state. So patients chronically having like a low mood, they're not extremely depressed where they meet the criteria for like major depressive disorder, but they stay like just sad all the time, and it's sort of like this mild form of sadness for like at least 2 years or so. And you probably know people like that, right? Nothing ever makes them happy. It doesn't matter what happens in life, you know.
They don't experience joy.
No, nothing.
Yes.
Especially like patients, let's say, I would say even some patients with like PTSD or something that sometimes can be very depressed. Like regular daily activities of life, or let's say if you're stressed out about an exam or something, they feel like, man, that's so ridiculous. Like, how can you be stressed? Do you know what I've been through? Like that kind of mentality, like nothing ever like moves them, right? Or phases them.
Yeah.
That type of just, you don't feel anything about anything,
You're just numb and
you're
sad.
sort of numb. You're
and sad.
numb and sad. You're numb about
Yeah.
everything, and that's very important to pay attention to.
Absolutely.
And I know last time you were discussing like the different medicines that we use, antidepressants, or that we use to treat patients or geriatric patients that are suffering from depression. One of my favorite medicines, we'll go a little bit longer today, maybe like an extra 10 minutes, because we've missed all this time. We literally have been chatting, thinking the thing was recording. Until Dr. Bharti noticed, like, hey, let's pause here.
So we are recording here.
Yeah. So we'll go over. We'll probably like go to like 12:40 or something. So at least we'll get a little bit of information out.
So we
to
can
our
get
audience.
some important essential information.
Yeah. And so I know last time you mentioned some of the antidepressants and things like that. For me, for geriatric patients, one of my favorite medicines to use is like mirtazapine. And why do we do that? So for when patients are old, right, the old geriatric acronym, like you start low and you go slow.
Absolutely.
That's like most of the
medications
that we treat patients with. And so we usually will start patients at a low dose, but typically for depression, we try to choose drugs for their side effect purposes. So if I have a patient that is losing weight and they're depressed, I'll choose a drug like mirtazapine for a geriatric patient, because it has a side effect of making you gain weight. Yeah. And so then they will gain weight, right? That's a side effect of the drug. And it will help with their mood as well. Yeah. And if they need an adjunct therapy, like we talked about last time, we'll add an adjunct, medication.
So usually, after we have made the diagnosis, we spoke about how we make the diagnosis for geriatrics, depression in our sequel, first part, and now we're in sequel 2.
If you come closer, I think we're getting out of screen here.
So the treatment we start, I and I'm sure Dr. Lopez will agree with me, I believe in doing what we call is biopsychosocial treatment. And my patients who are watching me, they know that I've always mentioned that studies show medication and psychotherapy together combined gives the bestest results in achieving effectiveness towards this clinical depression in geriatrics. There are multiple classes of medications. She talked about mirtazapine. One thing that everybody must have known by now is SSRIs, selective serotonin reuptake inhibitors. Yes. Then the other class is SNRIs. There is another 2 classes that I don't like to use in my geriatric patients, and I'm sure you'll agree with them: the tricyclic antidepressant class,
definitely.
and the monoamine oxidase inhibitor
because
class.
they're toxic to the heart. They cause a lot of cardiotoxic
So
stuff.
I and Dr. Lopez, when we have our geriatric patient, we actually look at their entire medication history. Mm-hmm. We have to look at their comorbidities, and we choose a medication that will not only give them the less side effect, but also won't interact with their other medications, because a lot of these medications can interact with your other medications that you're prescribed.
And I'm thinking of one common one, like a patient, I think bupropion, is very well used, right? Yes. And for depression for patients, and it helps also with smoking cessation. Absolutely. So once in a while, we'll see that patient where a doctor put them on bupropion, and then they saw another doctor somewhere who put them on another form of bupropion branded as Zyban, right? Yeah. And is used for smoking cessation. So the patient is taking all these bupropion, they become toxic on it. And what happens when you take so much bupropion? You get seizures, like things can happen. Mm-hmm. And patients don't know that they're taking the same drugs. And what we do a good job of going through all the medicines and sort of eliminating all the things you don't need, even all the over-the-counter herbals and a lot of things.
Because first, over-the-counter herbals can react with your prescribed medications, and not many people realize that. Yes. So as a geriatrician, our biggest job is to first make sure we have a thorough medication list from the patients, prescribed and non-prescribed supplements and everything.
Non-prescribed a lot of old people, a lot of non-prescribed, and it piles up. It piles up significantly.
So we do that, and then obviously the next goal for us is to use a medication that will give you the lesser side effect and most benefit. Keep in mind, again, we speak about medications, but I and Dr. Lopez highly believe that cognitive behavioral therapy and psychotherapy, or also known as, in simple terms, talk therapy, are very important to achieve good results with depression. And reason because cognitive behavioral therapy will help the patient learn techniques to cope with their symptoms, learn to recognize the negative thoughts, and learn to work on those negative thoughts so that their daily functional life can have a better quality.
Vitamin CBT. If you take nothing from this entire talk, vitamin CBT, go get it. You need that, and that's okay. It's normal.
I talk as if you can get it from Market Street.
You can get it from the store, right? Go get it. When you pick up your vitamin C, pick up some vitamin CBT as well. Call us. We will refer you and get you some vitamin CBT. We will help you with
vitamin CBT. Correct?
We will do that.
Absolutely. It'll be our pleasure. So therapy, as we spoke about, medications, there are non-SSRI medications too. She mentioned one was mirtazapine. She mentioned about bupropion. There are other non-SSRI medications which are very helpful in helping patients with their depression. One thing I want to say to patients that the medications we give for the patients, it takes about a while to show it into effect.
To work.
So I don't want you to start thinking, it was mentioned if I start a medication, my depression will be better. It takes time. Sometimes it takes about 6 weeks. I have told my patients, if you are watching me today, you know I have mentioned that it takes about 4 to 6 weeks to show into effect. But at 6 weeks, if I find that it did not help you, if I find that it's not working, then we adjust the dose. We can go up on the dose. Let's say if you were developing major side effects from it, we'll probably cut back the dose, or we can completely discontinue it and start you on a different therapy, again, meeting your profile. And then something she mentioned as well, and I had mentioned in my last visit, we augment the initial drug, which is that if your depression is getting worse and the medication that I initially put you on is not working and we have maxed out on that dose, then we add another class to it to help you fight and combat the depression. And again, all these things get much rewarded if you add therapy to that.
And if you are watching us right now, this is Tea Time with Quest Care. My name is Dr. Anilda Lopez, and my guest today is Dr. Jyoti Bharti.
Hi guys.
The amazing geriatrician who works with me here at the Quest Care Medical Clinic in Coppell. Yeah. So we're having, I know we're a little bit over time today, but we had a lot of trouble if you joined in at 12 o'clock.
But I'm sure you guys don't mind us watching.
You don't mind watching us. We're just chatting a little bit longer, maybe an extra 10 minutes before we go start back seeing patients. And so we'll just talk a little bit till like maybe 12:40.
Yes.
And
just
then
a little bit more.
And then we'll go see patients at 1. But anyway, going back, so if you are feeling like depressed, if you're dealing with depression from COVID-19, like, how do these patients cope? Like, I feel patients should stop too much media consumption. There's a little bit of infomania. I was listening to a webinar yesterday.
I love that term. Absolutely, infomania.
Yeah, I was listening to a webinar yesterday regarding COVID-19 and the vaccines and stuff like that. And they were talking about how there's infomania, right? And so it's hard to decipher like which information is accurate and what is not. There's so much data that's been published and things that are being put out.
At you, yeah.
Yes, and some of it is not even, a lot of clinical trials are not even done all the way, right? And they've already published it. And so then if we as doctors are having even a difficult time trying to decipher which one is accurate, what is wrong, what is right, and we have to depend and read like the reputable stuff like JAMA and like Lancet and things like that.
On our own.
Right, research those and read those because we can trust those, right? Those sites and those data. And so, if you're getting too much stuff from everywhere, too many sources, it can make you depressed, right?
Absolutely.
And you get overwhelmed. You don't know what is right, what is wrong, and what should I do, what should I not do. Absolutely. And, if those things are coming up and you're feeling depressed about it, well, come talk to your doctor. Make an appointment with your primary care doctor, and they have the accurate data and they can give it to you, right?
We try our best to keep ourselves updated.
We try to keep up with everything every day.
You're right. Patients are depressed not only from the pandemic and the infomania, but I've come across that unable to be with your loved ones, unable to have your family support. I mean, yes, we have to social medicate. We have to make sure we are wearing masks. We are not hugging. We are not loving. We are human beings. We are social creatures.
We're social beings.
We were made to have socialization.
I think you're too close. Give me 6 feet.
Exactly. I almost put my mask on.
You did.
But
you should wear your mask though.
Yes.
We're laughing, but we get tested for COVID, okay?
Yes.
Constantly. So we're clean. Dr. Bharti knows I don't have coronavirus, and she doesn't either.
We're safe.
We're safe. We get our temperature checked every morning when we get here.
We're taking all precautions.
Yes. We're taking all
kind of precautions just for the live sake today. We wanted to proper communication with you guys.
Because we're having issues.
We highly support masking and hand washing and distancing, 6 feet distancing. If not, watch my TikTok videos. They will tell you all. So having said that,
they should watch your TikTok videos. I love your Jerry TikTok video.
Yes, I'm so thankful to my patient who helped me make a wonderful video.
We should make more.
We'll work on it. If you and my patients are watching, just ask me if they want to do a TikTok video with me, and I'm sure I'll make sure.
We need to do an African one, like an African dance and an Indian dance.
And an Indian one, absolutely. Yeah. We'll make them out. We've been. Patients are coming in and it's kind of hard, but we'll do it. For our audience, we'll have our TikToks out, our fans out there. So having said that, guys, pandemic has taken a lot of social support from the geriatrics, which is a major cause for the depression at the moment that me and her are seeing it. I would make one humble request to my patients that please check up on your elderly. We are in this technological world. We believe in 6 feet distance, and I highly say we should keep our 6 feet distance. But hey, use your phone and do a FaceTime call. Yeah. Let them know that hey, we are. I'm just checking up on you, and are you okay? I'm here. Text message, voice text message, Zoom videos, maybe get together on the Zoom video with the all family over the weekends. These small things will add up and make sure the elderly depression either doesn't. First of all, hopefully it will prevent it, and then second of all, if they are already suffering from it, at least it won't escalate their symptoms.
And you need to stay active, right?
Yes.
If you're a geriatric patient, exercise is good.
Very
Walking is good. You need to walk at least 30 minutes per day.
Multiple
get a little bit of sunshine.
Sunshine.
Older women are more likely to develop osteoporosis. So it's important that you walk and you do a little bit of weight bearing. If you have those small little 2-3 pound weights at home, like lift those, and that will help build your bones. Things you can do on your own, right, without us needing to put you on medicine, which I think also helps with your mood. When you exercise, you feel great.
Feel good. Yes.
You feel absolutely amazing because it releases all these endorphins in your brain. And so exercise is great. Exercise is great for the body, for the brain, for everything.
A lot of times people with mild depression can achieve a lot of relief from exercise and social support from their family support. So I would highly recommend try those avenues before a medication is brought into the play.
And eating healthy too. Remember to eat well, eat healthy. No, it's hard to cook when you're old.
You're old, with this pandemic, going to grocery shopping.
Nobody goes out to eat anymore. Cook something. Learn how to make a new meal, a new dish. You know?
Absolutely.
I think we're out of time.
Give in to your hobbies.
We love chatting. I feel like we can sit here and talk all day. But next week we have the talk on depression and COVID-19.
Oh, wonderful! So we're
going to continue.
We did a nice preview today.
Yeah, it's a preview today. Next week we're going to do a better job. We're going to figure out the connection.
Sorry about that today, guys.
And get it better. We're going to do our little raffle. Do you mind giving it to me so I can look? Thank you guys for being patient with us and understanding our circumstances. Do you want to pick or do you want
Your turn today.
Are you sure?
Yes, ma'am.
Okay, let me hit the little thing. We have to get excited.
Da-da-da-da.
I don't want to look. I feel like I'm looking. Okay.
Her eyes were shut.
Yeah. DB. Okay, I'm excited. DB. So our team is going to call you in a little bit. You are a winner today. Dr. Bharti has your gift right here. So I will make sure. Oh my God, I hope I'm not pointing the name on the camera. Did I?
No, it was just, I don't think so. It was
DB.
visible. But the initials of your name, DB, we have your gift at the front desk. Please come and collect it to your convenience.
Yeah. All right. Thank you so much, Dr. Bharti. It was a pleasure chatting
Same
with
here.
you.
It was
So we
wonderful.
will see you next week at noon. Be on there. Share our video with your friends. Anybody you know. Get people to join us. Like our video. Comment on it. Put anything you want us to chat about next week, Thursday. Okay? Dr. Bharti and I will be here at noon.
Absolutely.
We'll continue this conversation. It was a pleasure seeing you. Thank
God
you.
bless. Remember,
God bless
tea time
you.
with Quest Care.
Tea time with Quest Care. Bye.
Bye-bye.
That's some delicious.